Welcome to the Low-Carb MD podcast. No one is beyond help. No one is beyond hope. Nothing said on the Low-Carb MD podcast is medical advice. Please consult your own doctor before making any lifestyle changes.
Hello and welcome back to the Low Carb MD podcast. I'm outnumbered by some East Coast people here today. Tro, how you doing, man?
We're going to have a lot of fun today. We're going to debunk some nutrition myths and, propaganda. So, I'm always down for debunking propaganda. And we have somebody who, he's like a dark horse. He's really like a dark horse. I cannot tell you how immensely valuable and helpful he's been to the Society of Metabolic Health Practitioners, to my own practice. And I'm very grateful for him and everything that he's done. We have Dr. Matt Calkins, who is a double board certified physician in family medicine and obesity medicine. He did his residency at Wake. Actually, he started as an ER doc, and he's been on the podcast before, but he started as an ER doc just to remind everybody. And then he saw the light. He said, I'm going to go to family medicine and primary care. And he's essentially devoted the last, I'd say, probably 5 years of his life to improving the entire field of metabolic health. He's published a number of papers alongside with me and Dr. Laura Buchanan, Dr. Adrian Sotomoto. And he is running a metabolic clinic, in North Carolina with Atrium One Health, who is actually a partner of Toward Health. And I'm super grateful to work with him on a ton of projects. But the most exciting project we're talking about now is the paper that he just launched. And it's attacking sort of the bunk that nutritional epidemiology is important and relevant. It's attacking it at its core. So we'll get started, and Matt can just briefly, tell the audience about him, and areas that I didn't fill in, and then maybe we could all just talk about what is nutritional epidemiology and what is this paper and what was your response to it. So I'll start there. Brian's already sleeping. He's like, nutritional epidemiology, I'm going to go to sleep,
No, it's good. It's good stuff.
But it's an important topic because it's important to everybody else, right? And so if you sleep on this, you're missing the boat on who makes the guidelines. So that was really the big motivation behind this. Is this, like it or not, this kind of rhetoric that was used is what shapes the DGA, the recent American Heart Association guidelines for their nutrition as well. So thank you, Tro, and nice to be on. Thank you, Brian. So I'm Matt. I'm a family medicine doctor, like you said. I went to University of Florida for my medical school, where I met my wonderful wife, Laura. She is certainly the greater half, and Laura Buchanan works with Tro as the other kind of co-conspirator over there. And really, we're just blessed to do what basically our passions are our jobs, and our jobs are our passion. So we were not in the nutrition vein at all in medical school. And that kind of showed up as me going to emergency medicine as a resident, as an intern. But actually, it was about 2016, 17, or 18, where we found the Low Carb MD podcast, along with some other resources on the internet. And for the first time, we were hearing that you can take people off of insulin, because up to that point, you're basically being told in medical school nutrition curriculums, which that's another topic we could honestly spend another day on, which has some exciting things going on right now. You're basically told that these conditions are chronic and progressive. There's no hope for the patient. There's no hope for you as the physician to make people better. Once they go on metformin, they go on the next medicine, insulin, and you're basically, whether you're taught it or not, you basically can read the data. And the more insulin you're on, the higher risk of the bad outcomes. And so we found Low Carb MD. Laura made the smart choice, and she is definitely the smarter of the two. She was going into family medicine anyways. And she started, as soon as she got into residency, started taking people off of insulin on near day zero. And I went into the different path of emergency medicine where you're just so far downstream trying to pick people up out of the river of chronic metabolic disease. Whereas I realized pretty quickly that I wanted to be upstream as far as possible. So made the switch. Laura then basically is now working with Utro, and I'm working local in North Carolina here at Atrium One Health, basically seeing patients, telling them how to do low carb if they want to do it, and taking them off of medicines.
I just want to say we are blessed to have Dr. Laura Buchanan work here. And I don't know, you guys are like neck and neck for the better half. I don't know. I'm going to say you guys are both amazing. And honestly, I'm going to say this with zero hesitation. The world and the field of metabolic health, I don't, it would, would not be the same, certainly the society hasn't been the same. Matt is so humble because he's not saying how much he's worked to get the Society of Metabolic Health Practitioners to get ACCME, PR1, AMA, PR1 credits for the education that we have moving forward. And that's just a little bit of it. He is the guy, responsible for that. So, and he's probably too humble to say that. So I will.
I appreciate it. Thank you.
Yeah. So, well, let's talk about the nutritional bunk. Brian, that they taught us when we were, when when we had to, walk to medical school uphill both ways. They said that eating meat is going to cause diabetes, and they said, it's bizarre actually. In the last 5 years, apparently ice cream is now improves diabetes, according to the nutritional epidemiology. So I don't know, Brian, you've seen the flip flops. So what have you seen in nutritional epidemiology? Sorry.
Well, I think we've had so many changes, and again, it always goes back to Professor Noakes and Gary Fetke, these guys who went through trials. I thought, this is the craziest thing. And they go, doctors shouldn't talk about nutrition. They're just out of your forum, right? And it's true, probably, because we don't get any education. And they just eat low fat, don't eat meat, and you'll be fine. Eat a bunch of vegetables because that's good for you. And that's it. We won't talk about muscle mass, outcomes, all the other data. So that's what I mean. Like, that's why this topic is so important. The epidemiology, it's crazy when you look at how like our food pyramid was based on these food questionnaires. Like, okay, over the last, like, no one knows, like, how many times you eat pizza in the last 10 years? I don't know. I have no freaking clue. But people come up with some answers somehow, and they're like, and a lot of it is they're saying what they want to look like they're healthy. So they go, I don't eat pizza. I don't eat those kind of things. But if you follow them around, and even, a lot of the data they did with nutritionists, and they had them, calculate their calories, and they were way off, and so it's hard. It's so hard if you estimate things, and then you base all these guidelines and, on that. So it's just been wild.
I can't tell you how many reversals I've seen in nutritional epidemiology. Eggs were good, eggs are bad, eggs are good again. Meat was bad, now it's not so bad. Maybe it is bad. So I don't know if we have a high degree of confidence. Which one of these findings do we have a high degree of confidence in? Matt, can you explain that to me?
That's what this paper, I think, tried to investigate. And so, to your point, Brian, as well, if you look at any individual nutritional epidemiological study, they will about 5 to 10% of people will either report calorie intake below 500 a day or above 4,000 a day. And one of the first things they do is generally throw out that data. So about 5 to 10% of people just have implausible right off the bat caloric intake. And to me, it's all about the exposures. It's just really hard to measure the exposures to the nutrients. Like, okay, can you accurately measure how much red meat they're eating, carbohydrates, fat? And I think time and time again, as you guys have said, it just doesn't add up to long-term good recommendations. So this study is a series of studies by a group in Europe. Schwinkschwackel is the main. He's like the PI of this PhD group over there that does these meta epidemiological studies, basically not just looking at epidemiology, but like the field of epidemiology itself. And with these 4 to 5 papers they published since 2021, they were trying to answer that question, Tro, which is how accurate are cohort studies when you look at randomized controlled trials? And can we just say that if we have a cohort study that shows this, would an RCT, randomized controlled trial show the same thing? So we just discussed the cohort studies have a lot of confounders, healthy user bias. People, generally eat salads because they think it's healthy, and then that goes along with all of these other health behaviors. But the randomized control trial is amazing because you can randomize people and you can generally get rid of the confounders. Problem is you can't really do the randomized controlled trials for these long-term nutrition interventions like red meat and colon cancer or fiber and colon cancer, which, by the way, I don't know if you guys saw this, a week ago, they published a study that showed that a vegan diet increased colorectal cancer. That was nutritional epidemiology as well. Do I place a lot of stock in that? No, because I don't place a lot of stock in any of these studies, but it kind of, that sword slices both ways, right? So they wanted to compare the relative risks of these matched. So this latest paper was the best paper they put out from their perspective because they elevated these comparisons. They basically took 54 pairs of cohort studies in randomized controlled trials. So off the top of my head, a few of these interventions were things like, and outcomes, was selenium and lung cancer. Another one was vitamin D and breast cancer from the Women's Health Initiative, I believe. They looked at Mediterranean diet and cardiovascular disease from PREDIMED, I believe. And so you basically go down the list, and there are 54 of those pairs. A lot of them were supplements. Not a lot of them were really macronutrient based or food based, which is a huge limitation anyways. And we can get into that as well, because taking a supplement is way different than actually measuring what somebody is eating. But the outcome of what they said is that, yes, they are cohort studies on an individual level and in aggregate to all together support the RCTs. So can we now say that red meat does cause colon cancer? Can we say that we have evidence, RCT level evidence from cohort studies that exists? And they believe yes. In fact, they say, quote, this is a quote from their study, our study shows clearly that most findings from individual RCTs were confirmed in best matching cohort studies. And we'll talk about that best matching in a second. And then they said,
hold on.
Yeah. You got to stop me. You got to stop me, Tro.
Hold on. I gotta ask you a question. So if you look at cohort studies, observational studies, right? These are big studies with people, for the listener, who are doing, questionnaires, and sort of there's some follow-up, and it's all about what you remember and what you write down more so than what you're actually doing. But in these studies, we've seen flip-flops, right? So carbohydrates looked bad 30 years ago. The Pure study, for example, in the last 10 years says, carbs looked good previously, fat looked bad previously, and now it's completely flipped around in the last decade, where looking at the same time frame, same populations, it looks like that maybe, carbs are not good, right? So how can you say that there's a high degree of certainty that this is correct when the observations flip-flop? How can you also say it's correct when the observations get weaker when you control for stuff like the healthy user bias? I'm having a difficulty understanding like their point of view. Can you, and not that you agree with them, but can you help me understand their point of view?
So I think if I were to steelman it, they would say that there have been advancements in how they collect the exposures. And then there's been new statistical ways to model nutritional epidemiology. One of the recent things that has come out within the past decade is they've done substitutions. So they can pretend that if you remove 100 grams of red meat and replace it with 100 grams of fiber, what does that look like for your risk of colon cancer? So it's still a model, and all models are wrong, but some are useful. But at the end of the day, it's really just more statistical based than anything really based in actual biological physiology at that point. And to the point about collecting exposures, I invite anybody listening, you can type into Google or your search engine of choice, dietary history questionnaire 3. And if you type in PDF after that, you can go to, I believe this is the NIH website, and you can actually click on the PDF link, and it's like in the middle of the page. I'm looking at it now. And it is a food frequency questionnaire, and this is how they collect this data. This is a relatively older one. I think this is probably like 3 to 4 generations ago, but I'm looking at it now and it's 142 pages. And the first question is, what beverages did you drink in the past year? And there's about 30 check boxes, and I'm not going to bore you with this. Actually, I was in the past year, and the first checkbox is tomato juice or vegetable juice, orange juice or grapefruit juice, grape juice, 100% fruit juices, fruit or vegetable smoothies, going down box by box. And then if you answer yes to any of those boxes, you then got to say how many times you drank that per month in the past month. And so I think one of the other things that people also classically bring up is, well, what about smoking? And I think there's a subtlety here, and unfortunately the answer is it's that it's complex, right? Smoking has a huge relative risk for lung cancer with relatively small variances, and it's easier to collect the exposure of smoking history. You just ask how many cigarettes do you smoke a day, and that generally doesn't change as much as eating or drinking these things, these 142 pages on the dietary health questionnaire. So to answer your question, the methods have evolved. The statistical modeling has evolved, but it's still not based on the biological principles, even with the modeling. It's just more and more statistical methods to publish more papers.
So walk me through, how is it that those who rely on epidemiology, how is it that they want us to view this data? Like you mentioned smoking. I think this is a great example. Actually, I thought about another observational flip-flop, alcohol, right? It's another one that's flip-flop. Before, alcohol was good in moderation. Now it's maybe not so good. It's another flip-flop. But how do they want us to view? Do they all want us to view every signal as if it was smoking, right? Like, hey, we're not going to do a trial of harm, and you should just trust that this is harmful and, move on. Like, how is it that people that promote this, what do they want us to do?
I think you can read the conclusions, and some people are more guarded than others, but I think when you start aggregating things into meta-analyses, even if each individual cohort study is guarded against what the recommendations are, like, oh, we need more data for this, we need more data for that. I think the basic data, and let's even back up, right? I care about the patient in front of me. And so nutritional epidemiology does not tell you about the patient in front of you that has diabetes, that has high blood pressure. Like we know from recent trials that the ketogenic diet can outperform the DASH diet, right? But if you were to just read the nutritional epidemiological literature, they always in general, they say low carb is less than 130 grams of carbs a day, which allows you to eat like Big Macs and fries and other high carb foods like that. And it'll show that maybe it is associated with hypertension, but it's not the same as a clinical intervention for the patient in front of you. So when they have these aggregate cohort studies, so they'll look at, let's just say they do look at low carb and hypertension. They'll look at it in NHANES, which is one epidemiological cohort. They'll look at it at UK Biobank. They'll look at it in the Women's Health Initiative, or they'll look at it in these other observational studies, and then they'll do a meta-analysis of largely low signal data that have large variances. And then when the meta-analysis comes back with a relative risk of 1.1 or 1.2, then they basically say, oh, it's confirmed in a meta-analysis, because that's the ultimate, that's the highest thing on the evidence pyramid, which is another whole other topic. But I think that's their idea. They have these studies that show these exposures resulting in these outcomes, and then they do the meta-analyses. And I personally think at the end of the day, the meta-analyses are basically looking at a bunch of just confounders and errors and biases that are propagated into that meta-analysis. But then they say, yep, we were right. Let's put it in the guidelines.
So basically a bunch of it's just a bunch of best guesses that they want us to take as, this is the best we got,
Yep. Without a whole lot of understanding of the risks of doing something, right? You, Brian, and me all know that every time we make a recommendation in medicine, there's a risk. There's a risk to coming into a clinic for an individual patient, and so there's less thought even about, well, what if we remove this from the diet? What are people in generally going to add back in? And we almost invariably see it's processed carbohydrates.
Yeah, 100%. So walk me through this paper that you criticized. Walk us through it. Like, set the stage.
Okay. So what they actually found is this. So they took these 54 pairs, and I just kind of described what some of their pairs were. And they took what's called a ratio of risk ratios, which is they took the relative risk of a cohort study and divided it by the relative risk of a randomized control trial. And so if they were exactly equal, so let's just say they were both 1, relative risk of 1, relative risk of 1, the RRR, the ratio of risk ratios, is also 1. But if both of those relative risks were 2, then you divide 2 by 2, that's also 1. And then if it goes higher and higher, like the relative risk of lung cancer from smoking can be as high as 60 to 100. If you have a randomized control trial that shows that a relative risk of 100 from a cohort study divided by a relative risk of 100 from a randomized control trial is still a ratio of risk ratios of 1. So they did this for the 54 pairs, and then they took into account the variance, or how imprecise these measurements were, and it was 1. So the cohort studies were exact. It was not only 1, it was 1.00. So it was exactly 1 over 54 pairs. And then the 54 pairs were the continuous data, or the binary data, essentially, the continuous data. There were 64 pairs total in the entire study. They basically said that 53 of the 64 pairs in the study total were in agreement, which is 80%. And so that's when they say our study shows clearly that most findings from individual RCTs were confirmed in best matching cohort studies. And again, they went on to say that the public health implications of our findings are therefore tremendous. That's a direct quote. So read plainly, that basically means that cohort studies are good enough. We don't need RCTs in nutrition, and we can build evidence synthesis and dietary guidelines on observational data alone with confidence. And so we didn't believe that. And basically, when I first saw their forest plot in this 2025 data, I knew that it was incorrect. And anybody can go look at this. And I have a Twitter thread up where I remade their forest plot. And the forest plot is basically a couple of estimates right around 1, but the error bars go off the forest plot, right? And so you cannot accurately say anything with the error bars being that wide. And so that's why we wrote the paper.
Yeah, and they come up with definitive conclusions. And I'm confused because I'm not a research guy. When you're talking about comparing to RCTs, do we have RCTs? It says keto diet versus vegan diet. How are they coming up with this, saying they're equivalent when you don't have that data?
So this is the other problem that I alluded to earlier. Most of these exposure outcomes were based on supplements. So there was a vitamin D in breast cancer exposure and outcome. And so vitamin D was a supplement in the RCT, and vitamin D was intake based on dairy and other vitamin D sources in the cohort study. And so they did look at a few, I think there was maybe 4 to 7 different types of actual macronutrient intakes. I know they had a low fat exposure. They had a Mediterranean diet. They had 2 Mediterranean diet exposures, looking at things like heart disease and whatnot. But the vast 50 of these, more or less, was just on supplements. So even if it was correct, even if you say, okay, we're going to believe this, let's steelman it and say that cohort studies agree with randomized control trials, it was totally not generalizable to any eating pattern. It was only generalizable to supplements.
So debunk it. So like, help me understand. Walk me through your entire thread.
Okay.
Like, because you talked a lot about it. So you mentioned a lot of different points there. Walk us through your response.
Perfect. So they said, so we asked basically 2 separate questions. So first, and this was with my co-authors, Adrian Sotomoda, who's brilliant, and also Isaac Nunez, who's a Harvard PhD student who was also really instrumental in a particular part of this paper as well. So we asked 2 separate questions. First, does that pooled metric, does that ratio of risk ratios actually distinguish real matching from random matching? So keep that in mind, real matching from random matching. And then second, even if that metric is flawed, so let's say it doesn't work, do the matched pairs, when you look at each individual pair of the 54 pairs, do they at least agree better than random pairs do? So we basically took those 54 pairs and we shuffled them 10,000 times. So you're now comparing a cohort study that is vitamin D and breast cancer with a randomized trial that looks at selenium and lung cancer. Does that make sense?
Yeah.
It makes no sense. Yeah, it's absurd.
I mean, it makes sense. You're criticizing them.
Yes. So it's just an absurd way to look at their data. And what we showed is if you do this even 10,000 times, you could more than likely do it 100,000 times or 1,000,000 times. What the answer we got with that randomized nonsense data was the exact same, statistically indistinguishable from the outcomes of their study from the best matched cohort RCT pairs. And when I say best match, they went through these things with a fine-tooth comb. They did this thing called PICO, which physicians generally know about because they teach us this in med school. They matched based on the populations, the intervention and exposure, the comparisons, and the outcomes. And so these are 54 of the basically creme de la creme, the best possible pairs you can get across all of the data out there. And we randomized it and we got the exact same ratio. Our ratio of risk ratios was when we pooled them all, it was 1.03, but 9,996 of our randomly paired ratio of risk ratios were within their confidence interval for their single ratio of risk ratio, right? So only 4 out of 10,000 was out of the range expected by their own statistics.
That's, I mean, so basically it's unreliable.
Totally. So that's it. So they're carefully matched results. It's statistically identical to what you would get from a random number generator. That's basically what we showed. So the metric cannot tell the difference between the real data and the randomly generated data by the random pairs. And so why is that? And it's because you can have an average ratio of risk ratios of 1, even if lots of the individual pairs disagree, because the positive and the negative differences cancel out. I invite anybody to go look at the Twitter thread or just look at this paper. This goes back to what we said. The confidence intervals are so wide, and every point estimate is generally about 0.8 to 1.2. So all of the relative, I mean, you know this, when you even look at the colon cancer and red meat data, what are the relative risks generally, even for that data? It's around 1.2. So it's very close to 1. And so when you start averaging things that are close to 1, 0.8 here, 0.9 there, 1.1 here, 1.2 there, then it's going to average to 1.
Yeah, I mean, look, Look, this just makes me more and more convinced that that nutritional epidemiology needs to end. You know,
Well, yeah. And I think what's a little bit frustrating is I'm just a simple family medicine doctor, and a lot of these statistics I was not the most familiar with. I had to learn a lot. I saw this paper back early 2025, a year ago now, and I saw their tremendous public health implications. And the worst thing that I could foresee happening, and it would, for a fact it would happen, is this would become a citation in the next dietary guideline. This would be a citation in the next American Heart Association nutrition guideline, basically saying that we can elevate the level of evidence of these studies to a randomized trial. And so that was only part one, by the way. Part two, we actually disregarded that whole metric, and we looked at these things as pairs, because remember, they said in their response, if I remember correctly, let me get it up here. They said in their response that there was 83% high agreement. 53 of the 64 pairs were in high agreement. And so we wanted to also investigate that. So the next thing we did is we looked at individual pairs. So we still randomized everything, but we looked at a pair of their original pair of, let's just say it's a vitamin D and breast cancer cohort study and randomized trial, and we compared it to the cohort study of vitamin D and breast cancer to the randomized trial of selenium and lung cancer. And when you compare them on the individual level randomized, there still is no difference than there is no statistically significant difference. The randomly paired values line up just as good as the perfectly paired values in the study.
Yeah, it's so frustrating because people take that day. You heard these docs. So I forget his name. The one who was always fighting with the carnivore guys, and he goes, "Well, one egg is like a pack of cigarettes smoking. Like, how do you make that?" They come up with these crazy things, and they go, "If you eat red meat, you're going to get diabetes." And you go, "Wait a minute, red meat in consumption has gone way down, and diabetes going straight up." It's like, that's why I like these guys who make clinical. And I think that's what we all do. You make clinical observations and you go, okay, I put someone on red meat and their diabetes resolves. Like, how does that happen? Like, if red meat's the cause, and that's why, like William Davis looking at, like, why am I putting stents in people's hearts that have LDL of 70 if LDL is the problem alone? Doesn't make sense. So he started looking at other stuff and he's like, oh, maybe this gut microbiome stuff, So I think there's so much involved. And I think also you can't just look at diet alone. You have to look at stress, sleep, other cofactors. You're living in the inner city or you're out in the country, like the Mediterranean diet. You live in the Mediterranean lifestyle, a lot different, So I think we make so many conclusions that you go, okay, there's a lot of factors involved. It's not just a simple, you just don't eat red meat and you don't die of heart attack stuff. Plus, with William Davis, he goes, a lot of these people that were coming in were pescatarian and vegetarian, and I'm putting stents in their heart. How the hell is that happening? If red meat's the problem, so he starts asking questions that no one else asks, and all of a sudden he starts looking into it and go, oh, look at this. There's correlations here that we need to investigate. But it seems like I don't know, it just seems like the science is so bad on this area.
I agree. I think you have, if you were to take the 10,000 foot view, I think what happens is this: you have a large drive to publish papers in academia to get tenure. So it's different at every institution, but I know maybe one institution says you got to have 10 first authors a year, or another one says 20 first authors a year. And it's hard to do like really good trials. Randomized controlled trials can take 5-10 years. But when you have this readily available data source that you can basically kind of torture to what you want it to say, there is no pre-specification in this stuff. They have a data set and they can do an analysis. And if it doesn't give them what they want, they'll do it again. And they'll do it again. And they'll do it again. So you're basically p-hacking without ever even showing all of your analyses. And it's this thing called, and Ioannidis, John Ioannidis from Stanford is like, he's the guru in all this. So if anybody is more interested on meta research, that is somebody, just watch all of his YouTube videos, because everything he says I basically agree with, and that's how I feel about this. But you got to solve this issue by pre-specifying your analysis. You cannot just keep doing analyses on these different data sets. You'll have one group doing the same thing to the UK Biobank, to the NHANES database, and there's this bias called the white hat bias. And so white hat bias means that the people doing this, the PhDs, they think they're doing a good service by finding the correct answer before they even looked at the data. They know what the answer is going to be, so they'll figure it out. Like what analysis do we need to do to show that people need to stop eating red meat?
Yeah, that's the big trouble. Like, anyone who knows the scientific method, and I'm not a big scientist, but your job is to prove what you believe wrong. And that's why when I see something that doesn't fit, I go, okay, why is this happening? Either I'm wrong or there's another factor involved, right? And that's how I went down this whole rabbit hole looking at endotoxins and gut microbiome. Why? How can someone have these small LDL particles and all their metabolic numbers look pretty good? And then you go, their gut is a disaster, and you fix it, and they go from pattern B to pattern A without being on a statin drug. And you go, okay, well, maybe there's a contributor there, And I think there's so much that we have to learn, but it's hard when you want the study to match your conclusion instead of proving it wrong. That what we're supposed to do is, I have this idea, I'm going to prove it wrong, right? That's the whole purpose of why we're doing it, trying to prove it wrong. And if you can't prove it wrong, you go, okay, that's probably a good idea, right? Sure, yeah. I know you have to say something.
No. I think that for a long time I've suspected a lot of like inherent bias. Like we just all want to prove what we want and think. So like I get it. I get the human instinct to do that. I also get the idea of sort of using the literature to support a ideologic agenda. I understand that, but I think it's come to the point of significant harm, and it's gotten to the point of delusion, right? And I think it just needs to end, right? The AHA basically said this week, we want to continue the failed food pyramid, right? And at some point you have to say, like, look at what's in front of you. It's not working, hasn't worked, and look at the interventional trials that directly negate all the basis for which you created these guidelines. And I think as a profession, we lack the humility, and particularly the AHA, and the ADA, they lack the humility and the introspection to say, what did we do wrong? And I think, you get personalities on social media that feel very strongly about a particular dietary, path. And I understand that. I get it. Like I feel very strongly about a dietary path. But when you torture weak data to prove a point, it's just, it seems like, at the least, let everybody eat what they want. Secondary, hey, metabolic syndrome reverses with low carb diets. I think the only endpoint that you could say is improved by a low fat vegan diet is LDL. And that's just say it. You don't need to say every person should eat this way, right? Like you don't have to say that. You can just say, we are dogmatic about this because, decreasing animal fat reduces LDL, and we think this is the reason why everybody should do it. Right? It doesn't have to be more than that,
But then you have to prove, like the Minnesota Heart Study, right? They had lower LDL and more events. You go, well, I don't care what your numbers are. I just don't want you getting stent and bypass surgery. You have to look at the outcomes. And it's the same thing where they go, well, triglycerides don't matter. It's a marker. So if you lower it artificially and they don't have good outcomes, you go, well, maybe it's a marker of poor metabolic disease and too many carbohydrates and maybe leaky gut, whatever else we talk about. But that's the problem is, okay, like when you look at these studies like this, I forget the name of the study, but it was 137,000 people admitted for their first heart attack, and 2/3 of them had LDL less than 130. And you go, and then these guys at 220, like it's not a straight up graph. It should be a straight up graph. If the higher the LDL is, the more heart attacks you have. It should be a straight graph going, and it's obvious that way. When you look at the data, you go, how come this guy with an LDL of 60 had a heart attack. Why? If that's the problem, right? If that's the only problem, you have to look and go, there's got to be another factor there that's involved.
I think, again, it comes down to, I asked this question. I was at a conference yesterday with some of the leading minds, and I'm going to pose the same question to you all. And the question is, why can't doctors, right? Like, one thing I saw during the pandemic, and one thing Brian, I've shared you the story of the residents who were calling something a wet read, and they didn't quite know. And the medical students, they didn't know what a wet read was. They didn't understand where it came from. And I thought that was interesting and comical, right? We still call it a wet read, and yet we've had digital films for decades, right? So, but the idea is, so doctors don't change. And I think maybe it's not and I think it has to do with the fact that, a number of things, but we don't question, as you start as a medical student and as you go onto a resident, you are the lowest man on the totem pole. And in fact, if you question authority, you could have your career jeopardized. And then when you go on to be a doctor, when you have, thousands of dollars of debt, if you agitate your system, you are going to, you can lose, financially. It could be really detrimental. So what I've found is that it creates real complacency. And then you have at the top end, these authoritarian, sort of dogmatic legacy doctors who put out these guidelines and don't want to be questioned. The AAP says, men could be women, women could be men, and they don't want to be questioned, right? The AMA, or says we should all be using CPT codes. They don't want to be questioned. The AHA says, use vegetable oil. They don't want to be questioned. So I think the problem, and I'm going to ask you guys this, why do you all think that doctors are unwilling to change and adapt to information? Why are they unwilling to question their own assumptions? Are we just unaware of the questions we should be asking ourselves? Are we paid to not question? Like, why do you think we're a minority? Right? Or do we have biases like everybody else and we're just not aware of them? I'm curious to hear what you think.
You take it, Matt. I'll jump in next. If you want me to go first, I will.
Ooh, no. I'll try. I'll try my best. It's an excellent question, and it's something that I've been thinking about a lot too, because I've been told in my relatively young career by allied health professionals and even other physicians that I'm killing patients. I was actually presenting my data, my 2-year data for my metabolic health clinic. I think there was it's like 300 people that have come through it so far, and average waist circumference was, I think, 9 centimeters improved. Average A1C was 1% improved, and diabetes remission. I had probably, I think it was 7 to 10 cases, and the weight loss was about 11%. And the main objection is, well, keto is fine in the short term, but it kills people in the long term. And so even I think when you're starting from that perspective, there isn't really a whole lot of reason to be had in the entire conversation. I used to think that we've accepted, just as a field, mediocrity in medicine. Like, I have even patients that come to me for metabolic health, sometimes there's this problem they've been dealing with for a long time. And I'm just like, oh, well, we can just do this investigation and we find out what the answer is for the problem, right? And I'm like, well, that could have been done a little years ago. Or maybe it's going the extra mile and explaining, like getting a calcium score and explaining what that is, and why that's a decent thing to get to further stratify risk, but not a lot of other people order it in this area. So I don't know if we accepted it, or if I don't want to victim blame here either. Doctors are under a lot of there's a lot of additional burden placed on doctors more and more and more, like going from 40-minute initials and 20-minute follow-ups to 30-minute initial visits and 15-minute follow-ups. You basically can increase the amount of people you see by up to 2/3 per day. And none of that allows you to go home and actually critically analyze and think, like, who's going to go home and read about Unwin's amazing diabetes remission data and actually figure out how to operationalize that in their clinic? Who's going to go home and read the Toward Health Frontiers data where we beat or are better than Wegovy? Even who's going to read the latest ketogenic schizophrenia, schizoaffective disorder, bipolar, major depression, and try to operationalize that? I think it's a knowledge gap, and it's also an operational gap. I think perhaps we've gotten too complacent and reliant on medications. And you can have a risk benefit like discussion about any medication, but can you really operationalize real change? Like Brian was saying, can you change a patient's exercise regimen? Can you get them to sleep better? Can you talk to them about food? And I don't think we can. I think that was lost. If we ever even had it, it was lost years ago. I don't, and like I said, it's just by the grace of God, Laura and I found Low Carb MD along with some other podcasts in medical school, because otherwise we would, you could just be another kind of in the machine, just a cog, right? But I think that there's a renaissance going on. There's a resurgence. I think that things like the Society of Metabolic Health Practitioners and the Coalition for Metabolic Health, these are organizations that are like growing rapidly in their attention. And we haven't even talked about this, and we probably don't even have time to, but there's very fun and exciting things with medical school curriculums. My goal by the end of the year is to give every medical student that wants one a CGM, especially with the recent HHS recommendations for actually focusing on nutrition. And I'll tell you one last thing too, because, okay, we went, where we went to medical school, we had 2 weeks of nutrition, and a lot of it was based on what step 1 and step 2 is, which is the main tests. Okay, so you got scurvy, you got pellagra, you got wet beriberi, dry beriberi, all these different vitamins and mineral deficiencies, which you do need to know. But what is the evidence for therapeutic carbohydrate reduction versus the DASH diet and hypertension? What is it for diabetes? What does Virta Health 5-year data say versus the direct trial 5-year data? What is the direct trial? What is Virta Health? And then not only that, but how do you operationalize that data and turn it into durable patient changes? How do you have the high touch point necessary to have these patients heal themselves and get off of their insulin, get off their metformin, get off of all these medicines? And that is a part of medicine where we just have a black hole at the moment.
Yeah, and my answer, Tro, yeah, those are all excellent points too. And Tro, my answer is doctors are sheep. We went into medicine because it's the safe. You're always gonna have a job. There's always job security. You're not gonna make billions of dollars unless you're going to Epstein Island and all that kind of stuff and telling people how to live forever and you're 38 years old or something. But the point is, doctors you don't want to stand out. There's safety in being in the middle of the pack. So when you and I started this podcast, we go, oh, this is taking a big risk because we're putting a target. But then we said, we're going to have doctors like Matt, all these people coming on saying what their experience is. And it's way better than the standard of care. So you can't have because I know you have this righteous anger, Tro, because I have that same thing. When I watch patients, we just put them on more and more insulin, more and more drugs. And you go, here's the protocol, here's the next drug. When that doesn't work, you add this drug. And it's easy because you could just throw a drug at someone and say, good luck, see you next time. You're on a statin. So if you get a heart attack, I'm not going to get sued. And then they have a bad outcome. So the problem is now we're seeing people with good outcomes, and we're like, that's the cure to burnout, really. So I think once people see it, I have residents all the time that come in and shout at me. I'm like, okay, when you go on rounds, you can't really talk about what you're seeing here because people are going to get really upset because these senior doctors don't want to hear, hey, why do you have them on a sliding scale insulin? You give them cookies and donuts and like all this orange juice and pancakes for breakfast, And it's incredible. Like they just can't get out of that mindset for some reason. I think it's a lot of it's arrogance in a way, or like you said, you have these high up authorities who say this is the way you do it. And I think the scab got torn off, or the veil was torn when COVID came. And we're seeing stuff, you go, this PCR test is not good. I'm seeing people get positive, negative, 4 days in a row. Like, how can that possibly be if it's a good test? If I have a blood pressure cup that says your blood pressure is 220 at one time, that's 90 the next, I go, wait, something's wrong with the blood pressure cup. It's not working right. Like, this is not normal, or there's something really serious going on. So I think there's so much, and you already raised that issue, Pro, is you're either low on the totem pole, so no one's going to listen to you, or you work for a system, and if you say the wrong thing, you're gone. And you have, trust me, I had $500,000 in med school loans. I can't afford to not to have a job. That's why I'm licensed in 2 states, because I go, you know what? If they say something that's going to upset the medical board in California, I want to make sure I have a backup plan. So I think for telling the truth in a weird time period that we went through. So I think there's a lot of that where if people stake their whole, Dr. Lipid, your whole life is based on a certain premise. And all of a sudden you go, I was wrong for the last 40 years. Like, that's hard to accept, right? You put so much time and effort. But I think the biggest thing is not wanting to be questioned. Allow people to question you. If you go, hey, I think low carb is the best. Well, here's an example where it didn't work. Okay, let's look and see if there's other factors, or maybe it doesn't work for that person. So I think those are things that all of us have this open mind to go, okay, if what we're doing is not working, we have to change course. If my diabetic's getting worse sugars, we have to fix something, whether it's nutrition, stress, sleep, alcohol, smoking, right?
It's easy to just say, they're not doing it hard enough, right? It's easier to say that, or it's easier to say,
they're not listening.
This intervention is slowing the worsen. Like it's maybe worse. It's not. It's like it's helping prevent worsening, right? Making it even worse, right? So I think those are like heuristics I've seen doctors do to keep them doing what they're doing, right? Like, if I didn't do this, like, look how bad it would have been.
It would have been way worse.
It would have been way worse.
Yeah, it would have been.
Or they're just not doing it enough or hard enough, right? So I
not listening.
Those two are like the ways that doctors find themselves just pigeoning themselves into whatever they were doing.
Well, and that's why you have people like Dr. Unwin, right? We already mentioned him, Matt mentioned him. He changed his whole thing because one patient came in and lost weight and came off her meds, and her diabetes and blood pressure and her mood, everything got better because she said, doctor, I stopped listening to your advice. I was doing what you told me to do and I was getting worse and I was taking more drugs. And then I looked and saw what my grandma and my mom did, and I did what they did. And lo and behold, I lost 100 pounds and I feel great. Body's better, right? So that's why it's their arrogance of saying what I'm saying can't make. And the thing that you and I both know, Tro, is I was doing the ADA's recommended diet. I was eating whole wheat toast like I was supposed to, and I was having green shakes for breakfast. My wife was trying to kill me, Melba toast and all this stupid stuff, and then you start realizing I have a patient who lost 40 pounds, cutting all those things out. Like, maybe I changed, or I just say, well, it was some other factor involved, right? So I think it's just it's hard for people to change. It's really, I think that's the big challenge, especially if you put your stake in the sand. And I think for us, like we've seen I think some of our ideas and views have changed over the last 5 years ago. Oh, okay, maybe we look at this other factor involved. Because if what we're doing, like, for instance, if keto worked for everyone, or a carnivore, if I have a carnivore and his triglycerides are 300, how can that possibly be? If sugar's the problem causing the high triglycerides, how can that possibly be? The only factor I've seen is fixing the gut, triglycerides go to normal. And they don't change their diet. We just fix the gut. So when you see that 80 times, you go, maybe there's something to that. Maybe it's just not a fluke for that one patient. So I think there's things where we change course, and I know you have, looking at different things that we can do to say, hey, if that's not working for that patient, maybe we have to change it up. But the low hanging fruit always is, what's your stress level like? Are you sleeping? Troy, you just had a great post about that. Nothing else changes, but all of a sudden you're gaining weight because life stress, parents sick. We have all these life things that get in the way. So it's not just what we're eating necessarily. It's not just the amount of exercise we're getting. It's a complicated game we're playing.
It's interesting. You talked about that thread about stress, and I have never deviated from a low carb diet, but I did eat, I would say snacked more. I would snack more. And all I did was stop nuts and dark chocolate. And I lost 10 pounds just in Lent. That was it. And it was dark chocolate with sweetener. It wasn't with like sugar. So whether it's insulin, calories, don't really care. When I get rid of these two things, and is it the food or is it my relationship to the food? I get stressed out, I eat those. I don't get stressed out and eat. I mean, I could eat anything, but like I don't, those are just easy and available.
Yeah. And the stress itself,
So
even if
I
you keep
went
everything the
carnivore. I went
same.
more
Yeah.
carnivore and I won. But other people, like I know Nick Norwitz, I've had this debate with him. He's like, try, I could eat as much macadamia nuts as I want and I won't gain weight. Right. Well, he may have a different relationship to those macadamia nuts, right? He maybe is eating it within his meal to satiety, right? I don't know. But Matt, what do you think?
I just think it's the patient in front of you, right? I think we've gotten so far away from that individual 20-minute, 40-minute encounter, or if you guys might have longer than I do. And that's why I come back to these broad public health recommendations that it makes our job just more challenging. Uh, Even theoretically, the DGA should be for a healthy population, and everybody in my clinic is not healthy. But they come in with your comment about eggs and cigarettes. Isn't it like killing my heart? And you're actually working from the pit. You have to actually climb up out of the pit to actually get them to the point where the change is going to happen because of these guidelines. At the end of the day, there's a lot of academic debates, and I think that I follow them and they're interesting, like the energy balance model, carbohydrate insulin model. Like these things are fascinating, but if you never tried to give somebody fiber that is carnivore that has trigs of 300, would you have ever like figured out that that was going to be something that would help them, or giving them some probiotics? And there's not data on that. I think the moral of the story from this entire kind of saga with this group, we didn't even talk about the response, by the way, which we can do that if we want to, but the response was not really worth a whole lot, honestly. I think
Yeah, give it. Well, to tell the listener, because the listener's like, what the hell? What do they say?
let me finish. So I'll finish this thought and we'll go to the
Okay.
response. And actually, it segues nicely into the response, anyways. Um, Real world clinical data. That's it. That's what we need. You just need anecdotes. And if it's working for the patient in front of you and they're getting better and their metrics are improving and they feel great, and if they're carnivore and you added in fiber and their A1C is going down, then just collect data on that and start publishing case reports and case series, and then do a cohort study. And then the data is out there. Tro actually published a hypertriglyceridemia paper a few years ago for 2 patients, and I'm actually using that as a citation in a case report I'm doing for somebody that had trigs of 2,000. We got them down to 400, and she stopped 210 units of insulin. And that citation is how I am going to help build the introduction onto why I did this and why it's safe, because she's tried a low fat diet for 20 years and she's had like 10, 20 bouts of pancreatitis on low fat diets. This is the first time she tried low carb, and within a month, her GMI on her Dexcom went from 8.4% to 6.4% off of, at that point, she was still on 20 units of insulin. So her A1C decreased by about 2% on GMI, and she went down 100, almost 200 units of insulin in just 1 month of low carb after 20 years of low fat. So where was the evidence for that? It was basically what Tro published, and then some of these organizations are now saying, okay, you can try low carb if there's an insulin resistant phenotype, but that never permeated to everybody who's been recommending these things to her. So long story short, I place a large amount of confidence in Unwin's data, in Virta Health, non-randomized but controlled data. I place a lot of trust in the Toward Health data, because this is real world evidence that's not randomized control, that you can actually work with patients on an individual level and actually see the real world results. And that's the difference between cohort studies and randomized trials in the real world.
Look, one of the things, I want to hear the criticism of like the response back, but one of the things is just to know it's possible. Like, hey, it is possible to go from 1,000 to 200, from 2,000 to 400, and here it is. It is possible to go from an A1C of 12 to 6, right? It is possible, take somebody who's literally making, alcohol in his gut and
that's an amazing story.
and
That's crazy.
Get their fatty liver to remit, right? It's possible, to reverse somebody's depression using diet, right? So like the idea isn't like, is this
now, Troy, you're gonna upset that pediatrician doctor who attacked me for that, saying that years ago, 8 years ago, 9 years ago.
That paper, the 2000 triglyceride, it is so important, right? Because
it's important because you guys you're showing clinically, here's what's happened. Like when Matt just said, hey, there's no data on fixing the gut microbiome. I've got tons of data sitting here on my computer. I give presentations on it, right? Because I go, I better be able to show 20 cases that I've seen personally to say there's something to this, guys. And so I think you make an observation, then you assess it. If you do all this stuff and then nothing improves, you go, okay, I'm wrong. And that's not the factor we're looking at. So there's so much of that. And that's why I love what you guys are doing. And it's so important to say, okay, let me question, why am I seeing what I'm seeing? And Matt said the most important thing of this podcast, it's the patient in front of us. Like I had to reach out to Troy. I go, I get this crazy case. I have the lady, she's, in Texas, she's 96 pounds when I see her, but her sugars are 300 every day. Her sugars are through the roof. All of her triglycerides are horrible. All of her numbers look terrible. And I'm looking at her. I go, are you the patient or the doctor? She goes, both. She's a type A doctor, working out 3 hours a day doing CrossFit, eats 0 carbs. I go, you must eat a lot of carbs. I don't need any. So what does she do? Exercise more and more and more, eat less and less carbs, and her sugars are getting worse. And so she's stressed out. So, hey, let's liberalize your carbs a bit. Let's add in some sweet potatoes and strawberries. And she's like, are you kidding me? I go, no. Let's do this and cut back on your exercise. And her sugars normalize. Right? It was all a stress response, cortisol. So you can't say, well, everyone should do what she did. Like everyone needs to do that. That's why it's so interesting. You see the Paul Saladinos of the world and Sean Bakers, people have a difference of opinion based on their life experience. And I think it's, people criticize Saladino for that. I make criticism for other stuff, but he saw what worked for him. He goes, I made this change, but you can't extrapolate, well, it works for him who surfs 4 hours a day and doesn't really working 12 hours a day like we do. Or if you're an engineer and you weigh 400 pounds, you cannot do the Paul Saladino. It's not going to work. You can't be adding in honey and right. So it's so individualized. And I think that's the take home is like, you cannot have, and I've always said this. That being said, now that they've changed the food pyramid guidelines, you go, cutting out processed food, is that going to make anyone else sick? Is it, cutting back on alcohol, all these kind of things, you go, there's really no bad outcomes to that. But some people probably don't have to cut all those things out, right? So you go, the more you could follow this, at least loosely, and the most important, the two thing also, Matt, you said, is the food pyramid. It says on there, this is not designed to treat any illness. So if people are sick, then it has no bearing. So there never should have been lawsuits against Fetke in the first place for this kind of stuff, because it's saying you're treating a disease process. This says it doesn't treat a disease process. And I'm saying, I think the new guideline will treat disease process because the other ones caused it.
I'm a fan. Yeah.
100%. Like, look, 100%, 150%. I'm in complete agreement. We need to keep demonstrating our clinical findings. Despite the pushback. I mean, this is StemWise is the greatest story about that. Yeah. We need to keep doing that. I'm curious, how was the response? I'm sure it was like, thank you so much for criticizing us. But just how was it received? Like, you spent that much time to give them constructive feedback. How do they take it?
So they always say, thank you for the ability to respond and all these things. So they open flowery, and then it really dives into the details. And I have some choice quotes here that we can say. And I really invite people to, and I mean, just plug everything into AI, just plug it into ChatGPT. Tell me say, give me an overview of what this is, and then put in my paper. What do you think about this paper with respect to the 2025 paper? And then give the response and say, was this an adequate response? And I think the answer to that is no. So there was a couple of key things they said that kind of, it was the only thing that really could happen was just backtracking of their tremendous public health implication and their rhetoric of just confirming cohort studies confirm RCTs. And so they said that the finding that our finding, so when we got our ratio of risk ratios statistically indistinguishable when we randomized it to their perfectly matched ratio of risk ratios, they said that that was neither surprising nor inconsistent. They basically said that that is what you expect when you do a pooled analysis on point estimates around 1. And so my rebuttal to that is, well, if it's not surprising, then you can't really use your data for tremendous public health implications either. Random pairing literally gives the same result, so why claim the matched results are meaningful? They didn't even engage with the p-values. Like the p-value for what we got compared to them was 0.12 and 0.48. So a p-value in this case below 0.05 would mean that their result is different from ours. So because our p-value is greater than that, their result is not different than randomization. And then they went on to say that, oh, we just hyper-focused on the ratio of risk ratios, and we didn't really look at their complete set of analyses. Their conclusions were based on their sensitivity analyses and looking at risk of bias and looking at the PICO matching in more detail. Basically, those were all sensitivity analyses of their primary analysis. If you knock the foundation of a house down, that the roof is going to come down with it. I don't care about the roof at that point, and I don't really care about their sensitivity analyses because we just proved that their primary analysis was bunk. They also said this was actually super interesting, and this was not in their methods, but they said in the response, remember we said that 53 of the 64 pairs agreed, right? About 83% of the pairs agreed. And so that was not in the methods, but they clarified it in the response. That was on visual inspection. So they literally looked at the forest plot, and in my Twitter thread, you guys, if you haven't read it yet, you should definitely read it. I have their forest plot. I remade it, and then I put just one of our 10,000 randomized forest plots right next to it, and I invite anybody to, by visualization, find any difference between them. And so the other thing that they did not publish in this paper is in their past papers, they looked at qualitative concordance, meaning they actually statistically compared the confidence intervals and the ratio, the relative risks. So imagine this. The studies would be concordant if they were both in the positive or the negative direction, with the confidence intervals firmly below or above that. So right, if the relative risk is 1.2, then the confidence interval would be 1.1 to 1.3, and that would be statistically significant, like relative higher risk. Does that make sense? So
I'm surprised.
You're still about the visualization. That's okay. We're getting to even the worst stuff here. So when you look at things that are either both positive, so both cohort studies and RCTs are positive, both are negative, or they're both like 1, but the confidence intervals are super tight. Generally, I think it was 0.8 to 1.2. Only 13% of these pairs actually met that definition. And that was the definition they used in every single other paper before this one, and they did not include it in this paper because that is actually the worst concordance they have yet. It actually has decreased from about 24% from like their 2022 paper down to 13%. So perfectly PICO matching makes your qualitative concordance worse. And the crazy thing is that's what we care about as doctors. We care about, does red meat cause colon cancer? That is a yes or no question. That is what this answers. And 13% actually only answer in the same direction or are both neutral.
So how do they take to all? I'm just, I'm sure there was email exchanges back and forth, right? How do they take to all this?
I mean, they didn't email us at all. They asked us for our data, like our randomization. I'm sure they had emails back and forth, but I think that their response is it's almost like they responded to a different paper. That's almost what it looks like. They responded to somebody else's editorial because they actually did not address 4 of the 7 major concerns that we brought up. And when they did address it, they started saying that they had these methods about visual inspection, and then they said things like it was neither surprising nor inconsistent. They torpedoed in some ways their own paper by saying that they expected our randomization to be similar to their real data.
Wow. Brian, what do you think when you hear that?
We have a lot of work to do.
Is it like narcissism,
and I'm going to go
or
back.
is it like gaslighting? What is it, narcissism or gaslighting? Or both?
I mean, do you know who sponsored this study? These are the things I think about. Like,
do we know anything about the authors?
Just that they publish a lot of meta-epidemiology. I think it would probably be more likely, and I can check, it's probably more likely that there's just a publish or perish mentality. That's all. I think the field of nutrition epidemiology comes down to that.
You think it's just like
do you want funding or you don't want funding?
I mean, yeah,
it's a big problem.
Did you look into the funding sources?
I'll check it. But imagine if you had a readily available, like 1 million subject cohort study right in front of you, and you can do 5,000 analyses on that. I'm not going to mention any names, but people can go on and look who's the most published researcher in America. And some of these researchers publish 300 papers a year.
Yeah.
In their PhD groups. And does that add anything to the scientific value? Does that move the needle for how you take care of the patient in front of you? I would argue, based on this study looking at the meta research aspect of it, that it just is overall not very helpful to the pool of scientific literature out there. And I'll leave that at that.
Brian, maybe we'll give you the last words. Listen, Matt, thank you so much for your work. Thank you for everything that you do, for the patients you care for the effort you've put in at the SMHP, for the help you've done working on these papers with myself and with Adrian in this paper today here, with some of the colleagues we talked about. Just thank you, because you don't have to do all this. You could be with your 2 kids, enjoying them. You could be going on vacations. And you don't have to be doing this. So if you're a listener, here, and you want to help Matt, well, 1, he's got a metabolic health clinic in North Carolina. Go find him. 2, I heard he's going to be a potentially medical director at some great clinic. I don't know. We'll see if that happens. But 2, donate to the SMHP, which Matt works with, and support us. Follow us online, spread our papers, and support the work that we do. Matt, Brian, maybe I'll let you chime in here, and then Matt will give you the last word on how people could find you, the paper, where and how they should follow you, and all that. But Brian, go ahead. Sorry.
Yeah, I'm just laughing because I remember meeting Matt. I don't even know what conference it was at, and he was this young little, med student guy, and all. I'm like, these are a cute couple. They're interested in this stuff, and look at they took on the torch, and they're just doing so much. So it's such a blessing to see that, because it's hard. A lot of people I think it's one of those things that's really hard, and I think if we had more people doing metabolic health and having residents and med students float through our clinics, and they see it and they can't unsee it. They're like, what do I do? It's like, it's so mind blowing when they go, you're taking people off insulin. Like when they meet the patients and hear the outcomes, that it's just mind blowing. And then you go to other clinics, like, they never see this stuff. Like your clinics in the hospitals, you just don't see it. So yeah, it just gives me hope for the future. I think there's a lot of good changes coming, and I'll have to go back. I can't remember her name, Tro, from the Charlie Foundation. She goes, "We just have to be patient." Like, you've been doing this for 32 years. Like, how patient do you have to be when you have these outcome data? So I think it's
That
just,
was Beth. That was
yeah,
Beth
Beth,
from the
yeah,
Charlie
yeah,
Foundation. Yeah, she's
yeah, and it was
amazing.
just mind blowing. Like some of the data she has, to go, oh my gosh! But you do what you can for the patient in front of you. You go, my patients are going to be taken care of. They're going to be at decreased risk of all these things we're worried about, and that's what you have to go by. It's not really. I don't care about the opinion of people who see patients, or I mean, it's one of those things. You just have to go by clinical experience. I think that's what Dr. Unwin taught us, is like, trust your clinical instincts. And I think that's, when you're in primary care, I think that's our job, is to see something that's not working. We got to tweak something. But if you have 8 minutes, how are you going to tweak something and know what you're trying to tweak? I mean, that's the system is a big problem. And I agree with Matt. It's not that the doctors are bad people, but they're beaten down. You're working 18-hour days. You're not going to go, oh, I'm going to read the latest study by Tro, some guy who I don't know anything about. So I think it's just a huge problem with burnout, stress. A system where you have to be more efficient. I worked years trying to be more efficient, and now it's like, I want to be more effective than more efficient. I think that's what it comes down to.
Matt will give you the last word.
Yeah, echoing what Brian said, Laura and myself had the wonderful luxury of working for 1 week with Eric Westman at Duke, and 1 week with Tro in residency during our elective period. And there's a lot of knowledge base you learn in residency, and our residency was awesome. Highly recommend it to anybody who's in family medicine. But in terms of just what we do in the clinic day to day with the nutrition recommendations, those 2 weeks were worth years of other just non-nutrition kind of lecture series and whatnot, and especially with kind of sit-down lectures of nutrition in other settings. So I highly recommend, if you're a medical student or resident, I think what we have to do, because it does get harder the longer you've been attending out of those institutions to change your practice. Get in with a metabolic practitioner in your area and see just what it's like, see the amazing improvements that patients can have, and see how it is to talk to patients and provide that hope, and get them off of medications that they said they were told they would never be able to get off of. And that's, again, this could be a whole other podcast that we could eventually have a good discussion on, but the Society of Metabolic Health Practitioners is actively creating a medical school curriculum, and also hoping to put that into residencies as well. And a big part of that would hopefully be to travel for a week to some of these clinics like we did, and work with a practitioner and make it easy and make it just ready to go, and basically make it be easy to be greenlit by the curriculum committee of your medical school, or whoever your residency director is. So I think that focusing on the patient in front of you, getting the clinicians when they're young is key. And I will leave it at that. If you want to find me, I am on Twitter, and you can actually, my most recent post was basically a big thread that went into all this in detail. There was actually we did a couple of more analyses on their paper that we didn't even discuss today, because we don't really need to but we did enough. Basically, it's just like the icing on the low carb keto cake. But if you want to really look at everything we did, go to Twitter. I am Matt Calkins, MD, MattCalkins, MD. And my latest post is just a full kind of thread breaking it down, and you can actually see the figures that we've been talking about, and you can come up with your own understanding of what you think of these papers and our response and their ultimate response.
Thank you so much for coming, man.
Yeah, sounds good. Thanks so much. Thanks, Matt, for all the good work you're doing. I know how much you're contributing and moving the science forward, so I appreciate that.
Shoulders of giants, guys. Thank you.
Yeah, and everyone, thanks for listening and your continued support. And Tro, lead us out, man.
Yeah,
Because I got 3 minutes
thanks
till
all
my
our listeners.
patient.
Yeah. Let's all go do metabolic health. Thanks to the listeners, and thanks for the Patreon supporters who are supporting us. Remember, Brian's practice and our practice needs your help. So if you're a long-time listener, you're looking for help, you're in Arizona, California, go out to Brian, and I'll take the rest of the country. So until Brian changes that. But we appreciate your help, and we appreciate your support. Keep supporting us on Patreon. Send this to your family, and come visit us if you need our help.
If you enjoy the show, please consider supporting us on Patreon by going to lowcarbmd.com.